Everyone see my screen here?
Yeah,
Great.
you're good.
Awesome. So, hey, everyone, I'm Noah. You don't need to pronounce my last name. It's Van Wingerden. My dad's from Holland. But Noah, one of the now PGY3s as of today at Temple. I think Warren got in contact with me through Gabe, who's one of our chief residents. So, thank you for having me. I think what you guys are doing here is really cool. I'm originally from Charlotte, North Carolina, went to Wake Forest for med school, did my intern year down in Charlotte, and now up here at Temple. So I've kind of been all over and seen PM&R in a few different places now, despite being just a PGY3 and in some away rotation. So today I'm going to be doing just a brief overview. Not, and I say brief because it's still going to be a good amount of time, but it's impossible to go through an entire admission to acute rehab and a neuro exam in 30 to 35 minutes, but we're going to do our best and hopefully I can teach you guys something so that if you guys get pimped or if you're just trying to look cool to the residents, you come away with something from this. So first, given that we're starting here, physiatrist, if you guys are third year med students or fourth year med students, first PM&R rotation, there's two ways to say this. And it's just a bad look if you say it wrong. So just start off on something chill here. So it's either physiatrist, or if you talk to someone like Bradham, he'll say physiatrist. So I would just kind of go off the vibes. If it's a younger guy, I would say physiatrist. If it's a younger or older gal or guy, then I think you say physiatrist and just see how it plays for you. But what we do, we help restore function through diagnosis, treatment, and management with every specialty or just within ourselves to help people maximize their functional independence, try to get back to where they were after a big event that may have decreased their independence and function. So some background. What does our field have in-depth knowledge about? Like I said, we specialize in function and things that a lot of things. So we've specialized in impairments, and an impairment, and I'm going through these terms because they're important to know. You'll get board questions on them, and also it's just nice to know if you see someone talking about it in a chart or insurance, you know what they're talking about. So impairment is any physiologic and anatomical or psychological loss of function. It would be someone's weakness from a stroke, confusion from delirium, or an amputation. What comes from that is an activity limitation. That's a restriction resulting from this above impairment. So if I have weakness from a stroke, the inability to walk is my activity limitation. This is the new word for disability. So if you see disability, it's synonymous with activity limitation. Next would be participation restriction, and that's the disadvantage for somebody given these impairments or activity limitations. This is used to be called a handicap, but now this is kind of the new term as we try to make words and terms more patient friendly and patient centered. So an example of this would be, so if I can't walk because of my stroke, then that wheelchair accessibility is something that I cannot participate in and it restricts me from doing something that I used to be able to do before everything happened. Who are we admitting to acute rehab in the first place? Who are our patients? Because we think a cardiologist is going to see someone with heart disease, high blood pressure. Who's our typical patient? So we're going to see a lot of strokes, TBIs, MSK injuries, as you guys all know. I'm not going to steal everyone else's thunder that's on this call and took time to make presentations, but just for the inpatient acute rehab side, we are going to take patients who have declined from their baseline functional status due to an inciting event. This can be a sudden stroke. This can be an ongoing coronary artery disease that eventually ends up someone getting a cabbage or a stent, and they have lost a lot of their function due to the deconditioning from this. And this is someone who's a great candidate for who's going to come to rehab. To get to rehab, you need to have two functional needs, or you have to have functional needs within two disciplines in rehab. So the three main ones, and I'll go through all these, but physical therapy, occupational therapy, and speech. So there's pathology. You can't just have PT needs. You need to have at least two of these. Most people, it's just PT/OT. In rare cases, you'll see people who are great from a physical therapy standpoint, but still have OT and SLP needs, so would still qualify. And to come to acute rehab, you need to tolerate 3 hours of therapy over the course of a day for 5 to 6 days a week. Usually, this is taken from PT and OT notes within the acute hospital. You guys won't probably be part of these decisions now, but as you become residents, you start becoming part of these decisions, especially when you're doing consults. Even a PTOT says someone can do 3 hours. Do we really think, based off our physical exam, that that's likely? And there's nuance there, but that's just something to mention. I know that. So this wasn't going to initially be on my presentation, but I saw that someone wanted me to go through, so I'm happy to do that. These are inpatient rehab diagnosis codes. Essentially, in every inpatient what did I do there? Every inpatient rehab needs to have 60% of their diagnoses be within a rehab diagnosis. You're allowed to take people who had toe amputations or just debility from a fall without a broken bone, but that can only be up to 40% of the people you take over a year to your inpatient rehab. So on the left, can you guys see my mouse here or no?
Yeah, you're good.
Yep.
Okay, cool. So on the left, these are when we first did rehab, when we started out, like really in the 30s, 40s, but now we've come to here for 13 different diagnoses. Stroke, that's obvious. Brain injury. So the brain injury, this is going to be your traumatic brain injuries from trauma, or your non-traumatic brain injuries, say from a brain bleed, a tumor, stuff like that. It does not include brain injury like, some woman got a UTI and got confused, or some male got cellulitis and got confused. That's not a brain injury. That can be part of the other 40%, but that's not going to be included in this kind of thing. Amputation needs to be, can't be a hand or foot, needs to be either through the radius, through the ulna, or through at least the tibia to account as one of these conditions. Spinal cord injury needs to have evidence of either weakness, paresthesias, or other losses of function. It can't just be a compression fracture or a radiculopathy, but full strength everywhere. For a femur fracture, it needs to be above the lesser trochanter. You can't have a distal femur fracture where one of the condyles are chipped off. It needs to be either through the neck or at the hip. So then we got neurological disorders like MS, multiple trauma. These are going to be your MVCs. Congenital deformity, that's more going to be in the ped side. Burns need to be third degree. For someone to get admitted for osteoarthritis. So you don't see a lot of these, just given that a lot of patients do pretty well in the outpatient setting. But if someone's going to be replaced for just osteoarthritis without surgery, they need to have 2+ weight-bearing joints that are causing them dysfunction, in addition to all the other things we already discussed. Rheumatoid arthritis after failing outpatient PT can come to us, especially for their OT needs with hands and just kind of fine motor stuff. If you get a joint replacement, it needs to have one of these underqualifying factors. It either needs to be a bilateral joint replacement, the patient needs to be above 85, or their BMI's got to be above 50. Systemic vasculitides, you don't really see those, but it doesn't include your septic arthritis. That's more along the infection, debility kind of side in the 40%. So what am I looking for? So say we now all know all the diagnoses, we know who's going to come. What am I looking for in someone's medical history as they're coming to rehab before I meet them? First thing is just general HPI. What led them to getting here? Was it a longstanding issue that turned into a cabbage? Was it just progressive MS that got them here? Or was it they felt fine, they were on their blood pressure medications, and then just one day they had a stroke? So you want to know the timing, what happened, and then also what happened in the hospital, and get into that. What medications were they taking at home that were changed, started, restarted, or stopped within the hospital? You can do this on the back end when you're ready to discharge someone from rehab, but if you do it on the front, and it's really nice to know these are all the medications they were on before. I'm going to have them in my HPI so that when I reference them to what they go home on, I can tell them this is actually what is going to be changed at the end. Because a lot of times, this happened today. Oh, I'm discharging a patient. He's like, well, why am I no longer on this medication? And I go back and I'm like, oh, we did stop that, and we just got lost in communication. So it's just really good to be organized from that standpoint. Based off their diagnosis, what are you expecting that they're going to need from you? Are they going to need a lot of pain management? Are they going to need spasticity? Are they going to need daily neuro exams? Just think about before they get here, what do you think is going to happen before you examine them? How are they getting nutrition? A lot of our TBI and stroke patients, they'll be getting nutrition through a PEG tube or TPN in rare cases instead of through the mouth because their condition has led them not to be able to swallow. So just that's important because it does change a lot of how you structure the therapy. You might, if they're on continuous feeds, you're going to have to structure therapy a little bit differently than if they were just doing regular meals. Were they needing behavioral interventions? Meaning, did they need to get put in restraints while they were there? Did they need Zyprexa because they were being aggressive with staff because of delirium or some sort? You need to be prepared for, you need to have a plan going into this. Okay, if this happens again, here's what we're going to do. Social history when you're admitting someone to acute rehab. You're still going to do all the things. Were they active? Were they riding bikes? Were they sitting down and watching TV all day? What did they do for fun? Still want to do alcohol, tobacco, recreational drugs. Usually that's available in the chart. You don't need to ask them again. But if you always just make sure you know about that. We care a lot more in PMR about the living space than when you admit someone to the acute hospital. I need to know what I'm going to get you back to. What are the obstacles that I need to get you back into your house? Do you have an apartment where you can have an elevator and I don't have to have you do any steps? Is your home set up for an adaptive setting? Do you have shower bars already? Do you have grab bars? Do you have a shower chair? Because I had someone the other day who had 56 steps to get to their apartment. If you didn't know that before, you wouldn't know that you need to start heavy and get stair training right away. So that's the importance. So steps to enter, number of floors, and where the bed would be set up would be the three things I would focus on. You need to know what kind of support they're having at home, whether that be from friends, family. Is someone going to be able to watch them 24/7 after, or are they going to need to be someone where we need to set the goals for them to just go home and then maybe someone comes and drives them to appointments every now and then? Where do they live? Sometimes important if they live far away, you just need to talk with social work about getting them out there and fixing that transportation up before. And then also, what's going to motivate them to get better? Do they have kids at home? Do they have grandkids? Do they have pets? You need to give them a goal and something to look forward to. You can't just say, okay, well, we're going to get better because I think you want to get better. You need to figure out the why behind that. So then figure out social history, figure out the medical history, then you figure out what were they doing before all this. It kind of goes with the social history, but what were they doing for themselves? Were they cooking, cleaning, bathing, eating? Were they driving? Were they doing taxes for themselves? All that stuff you want to know exactly how they were doing it, who they needed help from, who were they needing help with, were they driving, were they doing finances? Okay, I got ahead of myself, but were they still working, and if so, in what capacity? A lot of people were full-time working. A lot of people, this is not their first rehab stay and they had been working part-time. You need to know where they were before. You can't just assume that everyone was either retired or working full-time. There is a middle ground there. Were they using a cane? Were they using a walker? Do they already have shower bars, like I mentioned in the last slide? Then your current level of function, you're going to read this. So from the PTOT notes, mainly from the acute hospital, if you get them, and we'll go through this more. You can also call their physician, call their family and see if they know, but I would really just go off the PTOT notes. You can go off the pre-admission screen, which is what PASS stands for, but I honestly don't think that's helpful here. I think it's just best to look straight at the PT notes, figure out where they are. If you don't know where they are, then just wait for the evaluation the next day with PTOT on the first day of rehab. But how PT&OT structure your notes, they're with what we call the FIM scores, functional independence measures. It's 18 tasks, as you can see here, anywhere from eating to memory, scored from 1 to 7. We'll get into the grading score a little bit later. It's scored from 18 to 126, 18 meaning that they are pretty much total dependent on somebody, 126 meaning probably most like if you're outpatient with complete independence. It does have decent inter-rater reliability and validity compared to other impairment scores, so that's why we use it. I honestly, with the actual score, I find little utility in the actual score here, and that's just me personally. I usually look at a few things. Oops, someone's knocking on my door. 1 second. Sure. Hey, how's it going?
Good, good. Is Catherine?
Yes, she is.
Okay. Is everything all right? We just got a call from the concerned party about her.
Yeah, everything here. 1 second.
Okay.
Here, guys, I have like a family emergency going on. I'm gonna have to pause the presentation here and get back to you guys later if that's okay. I apologize so much.
No, not a problem. I'm sorry about that. Of course. All right. Hope everything's okay. I don't know if Dr. Apong is on the call yet. Oh, he is. Are you by any chance ready?
Oh yeah. Oh yeah.
Oh, awesome.
No,
Okay, great.
we're ready. We've been sitting learning about all the things, how to accept a patient to acute rehab. I was learning things that I was like, oh yeah, those are important things to ask. No, all joking aside, no, I hope everything goes well. Sorry to hear about things that are going on with the family. But yeah, I mean, whenever you guys are ready for me, I can also turn on my camera so you can see me in all my tired glory. All right, so I will go ahead. Let me share my screen. All right, you guys can see my lecture.
Yeah, you're good.
All right, let's start slideshow. And all right, so don't see any notes or anything like that. We're all solid here.
Yep, you're good.
Perfect. Awesome. All right, so yeah, I'll go ahead and get started. Hey guys, my name's Adrian Opong. I'm a PGY4 or now PGY4 at Jefferson PM&R. I'm also a chief resident there. I'm originally from Potomac, Maryland. I went to med school at Drexel, and did my intern year at Lincoln, and here I am. So I was very thankful and to be given the opportunity to present about the shoulder and the knee. This is mostly going to focus on a little bit of the anatomy and also just kind of like general concepts that I think are really important when it comes to examining the shoulder and the knee. I don't know how much time I really have given like the changes in scheduling, but originally I'm given 25 minutes, which going through shoulder and knee, it's not much time. But hopefully I can send out this lecture to y'all so that you can really go into a deep dive, appreciate some of the pearls in there. But I'm just going to be highlighting some of the high yield stuff when I'm actually examining the shoulder and the knee. See, there's a chat. Oh, perfect. Yeah. Awesome. So let's get started. So, here are the learning objectives. So anatomy, anatomy, anatomy. That is probably the most important thing. If you know your shoulder and knee anatomy, the bony anatomy and the muscle anatomy, and if you got some time, you can like throw in a little bit of like neuroanatomy in there. But I think those are like the high yield things because anatomy is honestly, if you know how a muscle or a tendon moves a joint, you pretty much know like what exactly is going on and you kind of know like what sort of maneuver you want to do. So that's why I say like first things first, understand your anatomy, pull up a picture. Like if you're in the office, pull up if someone's coming in for shoulder pain, pull up a picture of like what the shoulder looks like and just kind of like get familiar with that. And then the next thing is just to kind of gain a basic approach with physical exam maneuvers to help with your assessment of the problem at hand. So we'll start off with the shoulder. I'm not really going to go too in depth of this for the interest of time, but I think it's really important to know the important structures such as what the shoulder joint is comprised of. The shoulder joint is essentially the clavicle, the scapula, and the humerus or the humeral head. And what we know as a shoulder joint is really just the glenoid fossa of the scapula communicating with the humeral head. That is what we generally like associate with the shoulder joint. And I gotta say, the shoulder is probably one of the most complex joints in the body. Second to, well, the back isn't really a joint, but it's just as complex. And there's I mean, look at all this. You have so many areas that could be injured. It could be the biceps tendon. Supraspinatus of the rotator cuff is a huge one, major culprit. You have the delt, you have your labrum, you even have the articular cartilage here. You got the AC joint here. There's so many things, and I'm not even including the neck because sometimes they say shoulder, but you want to make sure do they have like a radiculopathy going on? That's also kind of on your differential. But we're just going to focus on the shoulder. But this is just me kind of highlighting anatomy is very important. And as we kind of go through the exam, certain exam maneuvers can kind of clue you into what could possibly be going on. So this is sort of the general structure of the shoulder exam: inspection, range of motion, palpation, strength. You have your maneuvers, special tests, sensation and reflexes. I mean, if you're really thinking about a like some sort of a neurologic process going on, yes, but most of the time we're thinking more structural. But in the interest of time, I'm going to go through the high yield things that are important to me that I think will get you to your answer. And that would be range of motion, active and passive, and the maneuvers and special tests. So range of motion tells me a lot. So what are the different ranges of motion? Shoulder flexion, and I have the pictures right here. So flexion, extension, abduction, meaning the limb is away from the body, and adduction, limb is coming close to the body. And then you also have shoulder internal rotation and external rotation. So essentially, internal rotation is when, let's say your elbow is at 90 degrees and you're essentially trying to bring the palm to your belly right there. You're doing internal rotation. Even when you're putting on a jacket or a coat and you're trying to put your arm in, you're already doing internal rotation. And sometimes you're going to hear that a lot with patients for certain pathologies. They say, yeah, it's really hard for me to put on my coat or put on a bra or even reach overhead. All of these things kind of clue you in what structure is being affected. So range of motion is the biggest thing, because when I test for range of motion, I just ask the patient, all right, raise your shoulder or raise your arms above your head, put them behind your back. And that kind of just tells me a lot. If they are limited, like they can't do it, then I'm like, all right, let me try to move them passively. And if I can't move them passively either in almost all range of motion, then that kind of clues me in. Do they have an adhesive capsulitis or frozen shoulder, or do they have osteoarthritis going on? Because these are mechanical things that's blocking the range of motion. Whereas if, let's say, the person has limited active range of motion because of pain, but if I move their arm and I can get the full range of motion, then that kind of tells me that this is more of like a tendon or even a ligament, or muscle-like issue. So things like rotator cuff tendonitis, a tear, or even like a labral injury, or even like biceps tendonitis. So already right there, I can, from range of motion, that already clues me into, is this a mechanical block or is this more of a structural, like let's say more of a, I would say like a tendinous issue that's going on. And so this is just to kind of like the reason why I put these pictures here. So the thing with frozen shoulder and OA, they can present very similarly. Patients can have limited range of motion in all directions. I know in the textbook it says adhesive capsulitis, decreased range of motion in all like areas, and the generally external rotation is the first to go. That's sometimes they'll ask you about that. Oh, they have frozen shoulder. Which is the first range of motion that goes away? It's external rotation. And maybe they'll start being like, oh, wow, this person really knows their anatomy. But be that as it may, they're going to have limited range of motion, whether they have frozen shoulder or osteoarthritis. The difference, sometimes you can tell with frozen shoulder, you move them, and yes, there's a locking, but you can kind of sort of move them a little bit, like there's almost like a soft endpoint. Whereas with, oh wait, this is like bone on bone, it's not moving. Like no matter what I do, it's stopped. But really, the best way to kind of figure this out is to get an X-ray. And with adhesive capsulitis, it's the capsule that's frozen or stiff, but the joint is for the most part fine. Whereas in OA, you're going to see that narrow joint space, and you're going to see some sclerosis, subchondral sclerosis. You're going to see some osteophytes here, all that stuff that you associate with arthritis. So range of motion is super, super important. And I urge you guys to do this. Always start with that because that can help a lot. Now, special tests. So I'm going to preface this. As med students, and even as like your intern year, or even as like PGY twos, right? We are just inherently trained. These special tests are what's going to give me the answer. Yeah, maybe, but I think the most important thing is the story, is the patient's history. That is what's really, I can spend maybe, if I can spend maybe like 5 minutes listening to their story, I can already figure out what's going on. And I don't have to do all of these tests because we think a test is what's going to lead us to one test is associated with one thing. But what you're going to notice is that the sensitivity is high, meaning like it'll tell if the test is positive, there's something going on there, but the specificity is pretty crappy. And so that's sort of the most important thing. But when you're in your training, definitely understand these, like know what they are, know what we generally test them for. So like Hawkins, like impingement signs, Hawkins, Neers, Jobs, those are more like for rotator cuff tendonitis or impingement syndrome. The crossbody adduction, AC joint OA or AC joint injury. So all these things I have them in parentheses. I won't go too much into it because of time, but the ones I think are pretty good are the impingement signs, speeds, and O'Brien's. And I'll get into those. And this is just me just mentioning like know them as you're starting your training, but as you kind of go further and further in your training, you're going to realize you're going to do fewer and fewer tests and you're going to develop your own style. It is a very busy slide, but don't worry, I have pictures. I think pictures speak 1,000 words. Really, what I just want to go through, I mean, you can read these on your own time, but I'd rather just go straight to the picture. But these are our impingement tests. So what do these impingement tests do? Essentially, what they're doing is, and if I were to go back to the slide, the rotator cuff, specifically the supraspinatus, it runs essentially from the supraspinous fossa of the scapula and attaches onto the greater tuberosity of the humerus. And what that does is it helps us with abducting our shoulder. And in that space, I kind of think of it as like a roof. The floor plan is the supraspinous fossa of the scapula, and the roof is kind of that AC joint slash the subacromial bursa. And if things get inflamed, or if that space is too tight, it's going to pinch onto that tendon of the supraspinatus, and that's going to cause pain. And that's what most of these tests are just doing. You're just crunching down on that subacromial space. So things like Hawkins, and I'll just go through the pictures. Hawkins, Neers, and these are just what I put in parentheses are just ways I remember them because for Hawkins, it's almost like you're flapping your wings like a hawk. For Neers, I think of Neers to the ear because that's essentially what you're going to be doing. You're kind of passively flexing their shoulder towards their ear. And if they have pain around like 120 degrees of flexion, then that kind of clues me into, well, there's probably something going on with the rotator cuff. And that's what most of these sort of show me. And the empty can, I know that's our favorite one. You all probably can remember how to do that maneuver. But if not, I have it right here. But really what that is not only are you kind of decreasing that space or crunching it down, but you're really testing for strength there. Because if, yes, the person's in pain, if as you're kind of applying that downward force on their forearm, and it's painful, yeah. And especially notice how I say it's the patient's shoulder pain. If it's just a pain, but that's not their pain, then that's not what you're testing for. But what you're testing for is to figure out is that reproducing their shoulder pain, which is what they're coming in for. It's painful, but they're pretty strong. They're giving you some resistance. Then that tells me more it's like a tendinopathy. But if it goes down like very easily, then that clues me in that it could be a tear. And I just want to also highlight here because there's a reason why I put in sensitivity and specificity. Look at the sensitivities of these guys 87%, 75 to 89%. But look at the specificity 30 to 50%, 25 to 44. These are good tests to like figure out that maybe this is what's going on, but the history is kind of what clues you in. So here's the pictures. Like I said, picture speaks 1,000 words. So Hawkins, essentially you have the patient flex their shoulder about 90 degrees and they flex their elbow 90 degrees. And what you do with you place one of your hands kind of proximal to the elbow and then apply a passive internal rotation force along the distal forearm. I'm doing this on myself and that's pretty uncomfortable. But with someone who actually has a rotator cuff tendonitis, you don't even need to like do that much. You just need to just bring it down a little bit and they will say stop it. They'll probably punch you in the face. And this is where I kind of say this. You can do any one of these tests, but if one of them is positive, don't do the other. I would stress don't do the other because one, their whole exam is going to be guarded and it's going to be like tough to tell. But two, it's enough. It sort of tells you, all right, there's something going on here. I can kind of move on, or it sort of based on the history and the exam, I kind of have my answer here. So this is nears, bringing near to the ear. So essentially, you have them maximally pronate so that the palm is actually facing towards you, and then you'll passively flex their shoulder or flex their arm all the way to the ear. And generally, if it causes pain at 120 degrees, then that's positive for some sort of tendinopathy that could be going on. And then this is the empty can test. Y'all probably have seen this a bunch in med school, but essentially what you do, you just have them essentially like pronate so that, or even you could tell them, pretend like you have two cans and you're pouring them out. And make sure that when they're flexing, always make sure that they actually adduct their arms maybe like 15 degrees. Because the reason for that is to make sure that they're in the scapular plane. And then you apply that downward force, and if it's really, really weak, then that clues you into a tear. But if it's like pretty strong, but it's painful, then it's most likely a tendonitis. Now, speeds test. This is testing for biceps tendonitis. So what do you do with the speeds test? So kind of in this picture, you just have the patient say, I want you to just bring your arm up to maybe about like, just maybe to like shoulder width, right? And then I say, have your arm up and have the palms pointing to the sky. And then what I do, I apply a distal downward force and I say, try and bring your arm up against me. And once they do that and they're like, ah, doc, I'm having some pain. And they point to, I would say like the anterior, like glenohumeral joint area, then that kind of clues me in that that could be a tendonitis of the long head of the biceps tendon. Because remember, the long head of the biceps tendon goes all the way to the glenoid labrum. So that's kind of where it inserts. And so it'll usually be more anterior. And so that kind of clues me in that there could be some sort of a biceps tendonitis going on. And notice how sensitivity is 63, 90%, but look at the specificity. And so again, the history is kind of what clues me in and doing maybe just testing strength, like bicep strength, and doing the speeds that can kind of clue me in. It's just to like confirm my suspicion. Now, O'Brien's. So it kind of took me a minute to like figure out what exactly, like why are we doing this? And then it kind of became one of my favorite exams. The point of the O'Brien's test, it's almost like an impingement test or like an empty can test before the glenoid labrum. A lot of people who come in with labral injuries, generally it's some sort of an acute event, like a bag, like maybe they were trying to catch something overhead, something really heavy, and then it just kind of like jerked their shoulders back a little bit. Or you see it a lot in like baseball pitchers because they're just really grinding down on that labrum. And so, or they could just be lifting something really heavy, like working out, and then they felt something in their shoulder. And they usually say, my shoulder feels really tired, or I feel like it's about to pop. But it doesn't really. So one of the things, what O'Brien's does, it's like an impingement test, but for the labrum. So what you have the patient do first, you start with a position that actually You can do it either way. You can have them like with the palm pointing up or pointing down. It's really on how sensitive they are with the pain. But what I usually like to start off with is I actually have them point their hand or almost maximally internally rotate their shoulder, and so the palm is facing towards you, and obviously they're flexing their shoulder to 90 degrees. And then what I do is you apply that distal downward force. I say, try and raise your arm against me. And then they're like, wow, actually, that's really, really painful. I'm like, okay, now let me have you externally rotate. I don't tell them externally rotate, but I also say palms to the sky. Now, try and bring your arm up. And they actually say, you know what? That's not too bad. That the reason why that happens is because when you maximally internally rotate the shoulder and you apply that downward force, you're almost like just cranking that superior glenoid labrum. You're really cranking it down. Whereas when you're when you're supinated or their palms are to the sky, it's adding a lot less pressure there. And so that if their pain is felt kind of around that shoulder, like the anterior or even superior aspect of the shoulder, then that can kind of clue you in that there's probably some sort of labral issue going on. But if they say, oh, the pain is kind of more where their AC joint is, then that's kind of more like an AC joint dysfunction. But again, history tells you a lot of things, but this is just something that you can use to kind of clue you in. There's something going on with the labrum, but that area has a lot of things going on. Remember what attaches to the labrum? The long head of the biceps tendon. So maybe there could maybe be some compromise of the biceps tendon, and even the rotator cuff is kind of around there. So that's why, even though, like I would say, sensitivity, I mean, the sensitivity is like 60 to 100%. But well, I would say for like I would say for like, let's say, AC joint injury, or maybe like 69 to 100% for like labrum, look at the specificity, it's like 42 to 98%. So again, history kind of clues you in, but I'm just showing you these are the tests that I do to kind of help me sort of figure out what could potentially be going on. So now I'm going to the knee. I really love this slide, and I'll even reference like where I got this from. There's a great playlist from UCSF's sports medicine program. They have a great series on how to do different exams, and I'll have the link in that in my last slide. But this is just such a great slide here. Not only does it say go back to anatomy, so the anatomy of the knee, right? You have the femur, you have you have the medial, and you have the lateral condyles, and then you have the tibia, patella, you have the LCL, the MCL, you have the ACL, and the PCL, and you have your menisci. It's pointing to each of these things that kind of tells you, it gives you different differentials. If they have an issue going on, maybe around like the condyles, okay, maybe it's either going to be arthritis, like degenerative process, or it could be like an actual acute chondral injury that went on. If they're having pain sort of around where the menisci are, it could either be a tear just based on their history, or it could just be arthritis that's just grinding it down, and so on and so on. And so this is why I say, if you understand your anatomy, if you know where they're pointing, you have a good idea what could be affected. And based on their story, you have a good understanding, like maybe this is what's happening. So same thing, knee exam. I'm really just kind of going to go through the things that I think are really important. And the most important thing, and I didn't even mention this for the shoulder, but for any kind of joint, check both sides. Both sides are going to, the intact side is going to give you a lot of information. It's your frame of reference. And so inspection, palpation, and obviously the special tests here are the ones that I kind of like emphasize on. So this is a pretty busy slide, but what I'm really just trying to get at is like, this is just my general flow of things. I first look, And what do I mean by inspection? I don't mean I am looking at the knee itself. I am looking at the patient as they're walking into the office or into the exam room. Are they limping? Do they have an assisted device with them, like a cane or a walker? Do they have a brace on? Because these things kind of clue me in, huh, okay, there's probably something going on. Or maybe they've had like a prior injury and maybe it could be aggravated or maybe they re-injured it. I'm unsure, but it's just something to kind of keep in your brain. And then when you're in the exam room, generally for like a pretty young, healthy individual coming in with knee pain, I honestly just have them, hey, can you try and do maybe like a single leg squat or just do a regular squat? And what I'm looking for, not only to see if their knee pain is reproduced, and if it is, where exactly is it, but I also do this to see, is their patella moving, like, is their knee kind of moving a lot more inward when they're doing these tests? Because that can clue me in that maybe they're having this pain because of a muscle like imbalance issue. So things like patellofemoral pain syndrome or runner's knee is a muscle imbalance problem. And I can gain that from just them doing a squat. Arthritis, obviously, you're grinding on that joint, you're putting weight on it. That's going to create quite a bit of pain. Meniscus, same thing. You're really squeezing on that, like grinding on that meniscus. And if they say, yeah, that really hurts, then already it could kind of like clue me in. These are like the three things I start sort of thinking about. And then the next thing, I have them sit on the exam bed and then I look for swelling. I look for swelling. Maybe, and if it's like a diffuse, and I'll get into like the fusions, but if it's like diffuse swelling, or even localized, that can kind of tell me, okay, is this like ligament? Is this arthritis? Or could it be gout? Never forget about gout. Never, ever, ever forget about gout because that is way more common than you think. So if they have swelling and erythema, then I start thinking of infection. I think of gout, or I even think of rheumatoid arthritis. That's where the history kind of comes in. So swelling, erythema. I don't really look so much at like muscle atrophy, but just a nice pearl. If you look at their vastus medialis, if you see that that's not as plump, like very muscular compared to like the intact side or the non-problematic side, that could be because they have really bad medial OA. And so whenever they're like grinding on that joint line, it causes this pain inhibition of the vastus medialis to activate. And if you don't use it, you lose it. And so that could lead to atrophy. So that's something that you can kind of clue in there. Deformity. So what I mean by that, it's kind of the same thing up here. When I see them do that squat and I like sort of see the knee going in, or even when they're not squatting and I see their knees are turned in a lot more, or their foot is like kind of overpronated, or rather it's just they're sort of like on the edge of their feet, it kind of clues me in that the angulation could be of their tibia could be affecting their knee, and that's something that's like a risk factor for runner's knee. And then surgical scar. But of the biggest things I look is swelling and erythema. Palpation is just feeling. So if I notice there's swelling, I gotta first realize, is it diffuse? Like, is it all over is it all around the knee, or is it localized? Like a prepatellar bursitis, or even like a pes anserine bursitis. They're mostly localized. But a more diffuse effusion is like you can like see, and I'll show a good picture of this, but you have dimples around the knee. And if you see on the intact side, those dimples are there, but on the other side, that medial like knee dimple is pretty much bulbous or gone, and that clues me in that there might be some sort of intra-articular damage going on. And what's within that joint? So the ACL and the PCL, or even osteoarthritis can cause this. So that's sort of what I meant by diffuse versus localized. Um, and sometimes the effusion may not be that prevalent. And so what I really do is I just kind of put my thumb and my finger just slightly above the patella, and I just push down from like almost like the proximal or like the distal quad tendon. Sometimes it's called a suprapatellar pouch with the other hand. And if you see both of your fingers spreading out, then that's a positive like test that they have some trace of fusion. That could kind of clue you in. Maybe this was an injury, like a tear that's just it got a little bit better, but there's still some effusion, like swelling in there. And then also I just sort of I palpate sort of the patellar tendon. If there's pain with that, and if that's what their pain is, then that kind of clues me in. Okay, maybe it's a patellar tendonitis. Same thing for the quad tendon. Palpate that, and even sometimes I have them activate their quads against resistance. And if that produces their pain and it's that area, then that's more of a quad tendonitis. And then I go for the money, and that's the medial and lateral joint lines. Now, when you do this, be sure, use one finger. You can use your pointing finger, or use your thumb, but just use one of those things. Do not use both, like palpate both joint lines at the same time. Because if they say ow, you're not really going to know which one. You're going to have to ask them, oh, where is it? And that takes up time. So start either medial or lateral. It doesn't matter. Palpate around all the way to the back. And generally, pain upon palpation along those joint lines can kind of clue you in that there's either a meniscal thing going on or it's OA. The meniscus is because that's where it is. That's where you're palpating. You're hitting on that meniscus. And then obviously going to the back of the knee, to the popliteal fossa. Why? They may have a Baker cyst there. And even sometimes like you have hamstrings, and sometimes we forget the head of the calf muscles are in that area too. So maybe they could be having some tendonitis there as well. So this is what I meant by the effusion. You can clearly see you have that dimple right here at the knee, and you can look at your own knees when you do this. See, it's really sunken there, but then look how it's just blown out. And it's even kind of more blown out here too. I didn't even put it in a circle, but right here as well. It's a lot more caved in. It's more concave, but it's way more convex. So that kind of tells me something's going on here. It's either gout. It could be like maybe like a ligamentous injury, or it could be OA. But judging by these knees, I don't know. It's a fairly young person, so it could be some sort of like a ligamentous process. Anywho, now we're at the special tests. So same thing, special tests, they're good, but you need the history to kind of like, you need the whole picture. But these are the general tests that I will do if I'm suspicious of something. So again, busy slide, but I like pictures more because they say they speak 1,000 words. But Lockmans. So Lockman and anterior drawer are kind of fairly a similar test. Lockman is a little bit easier in that you really just have the patient sort of, or you bend the patient's knee about like 20 to 30 degrees. And the reason why you actually do that is because that's probably the most, like I would say, the most loose that knee is. And essentially what you do, you kind of you stabilize the femur with one hand, and then with the other, you kind of just pull you pull upon like the back of their tibia or like the calf towards you, almost like you're sort of like starting a chainsaw, like you're revving it up towards you. And generally, if you see the test is positive, if like you see a displacement like greater than 5 millimeters. Well, what does that mean? Honestly, if you just use the other side to compare. If the other side, like there's a firm endpoint, but then you do it on the problematic side and it's like, okay, wow, it's really coming towards me, then that clues you in that it's either a partial or a complete tear of the ACL. And the reason why people actually like Lockmans more than anterior drawer is that not only is the sensitivity great for acute tears, but the specificity is like 95% for acute tears as well. Anterior drawer, a lot of you probably know the anterior drawer test, but regardless, have the patient bend their knee 90 degrees. You sit on their foot to stabilize it, and you use your thumbs. You palpate the I would say like the tibial flares, and you would just pull, just gently sort of like pull their tibia towards you. And if you see excessive displacement compared to the intact side, like very, very, very like excessive, then again, it clues you into an ACL. Now, these are good at detecting chronic injuries, at least for the anterior drawer. So if someone's like maybe an older gentleman or older lady, then I'll probably do anterior drawer. But for someone younger, or like let's say somebody had like a non-traumatic, like a non-contact injury, I kind of go for Lockmans because that's going to clue me into a acute tear. Now, if you're on the sideline and you see like a athlete just injure themselves and you're thinking, oh my gosh, like they did a cut and they said that and they just went down easily and they're like, I'm in a lot of pain. I felt like I hurt something, and you see it super swollen. Chances are that these tests are going to be positive are very, very slim because that joint, you only got one chance to do these tests. And as soon as you do it, that knee is going to lock up because of their acute inflammatory process. So a lot of these will give like false negatives if you're doing this from like the sideline for an acute injury. So that's why you sometimes have to kind of like give them like a few, maybe just like 1 or 2 days. But the first thing you're going to do, you're going to MRI them. Like I mean, just based off of the history and the exam looking at them, yeah, you're going to get an MRI. And then the posterior drawer is just the opposite of the anterior drawer. And this is just a test for PCL. If this is positive, meaning that tibia kind of moves further back, then that kind of clues me in that this is probably a PCL injury. And so this is what I mean by, as you can see here, the Lockman test. You have the patient flex their knee 20 degrees, stabilize the femur with one hand, and you just pull that tibia towards you. And if you see about greater than 5 mm displacement compared to the other side, then it's positive. Here's the anterior drawer, kind of the same thing. You stabilize the leg by sitting on their foot, bring it towards you, positive, kind of clues you into ACL. Posterior drawer, same thing. If it's excessive displacement posteriorly, then that clues you in to a PCL injury. And then here, the valgus stress test and the Vera stress test. These I'm really just testing for the integrity of the MCL and the PCL. So these pictures are swapped, but valgus stress test, essentially what I'm doing here is I am testing for the MCL. And how do I do that? So I place one of my hands at the distal end, kind of like at the ankle of the problematic side of the knee. And then I place my hand along the outside of the knee. And then what I do, valgus means kind of like bending towards the body or almost like an angulation. I push along that to create a valgus like moment or a valgus stress. And what I'm doing is I'm putting stress on the MCL. And you want to, and it's sort of it's the opposite for the Vera stress test. Varus meaning you kind of, it's almost, you're kind of moving a little bit away, like you're kind of creating like a bowing. That's varus. And you put a lot of pressure on the medial aspect so then you can push along that lateral collateral ligament. The reason why I think something that's important is you want to make sure that you do these tests initially as like with the knee fully flexed, and then you have it bent at 20 to 30 degrees. Why 20 to 30? Oh, sorry. Why 20 to 30 degrees? That is actually, again, that's probably the most loose, like relaxed that the knee joint is going to be in. And so if you see a lot of, let's say, medial display, like if that bowing is way more than on the other side and it's very painful too, then that's positive and that can kind of clue you into either an MCL or an LCL. And if you are worried about an MCL injury, I'm not going to ask questions in the chat, but then you can kind of think more like, well, what's connected to the MCL? Well, we got the ACL and the medial meniscus. That's a high yield concept. If you're worried about an ACL injury or a medial meniscal injury, best believe you got to think about, all right, I want to make sure that these, like all these three structures aren't involved. So very, very, very high yield. And then the last one is McMurray's. This, by the life of me, was probably the most confusing exam as a med student. But then they just required one thing, one thing to make it easy. But what is McMurray's test for? Essentially, what you're doing, you're testing to make sure that the person doesn't have like a meniscal injury or some sort of derangement. And so how do you test this? Well, what you first do, you actually like put what doesn't matter which hand, but you put your finger and your thumb and your index finger along the medial and lateral joint lines. And then you put your hand along the other hand along the heel of the patient. And the first thing you want to do is flex them, like flex them fully. Why do I say that? Because that in itself is a test for meniscal injury. Because what you're doing is you're crunching down on that posterior horn of the menisci. And if they're like, oh my gosh, wow, that's really, really bad. Okay, that kind of clues me in, especially with maximal flexion. Okay, there may be something going on with the meniscus, but just to really, really make sure, I'm going to be a huge butt face and grind on it. And what do I mean by grind? So with the hand on the heel, I am either going to twist the heel in or twist the heel out. And when the something that really helped me is this. Wherever you're pointing the heel, that like if you're pointing it inside or medially, that is the meniscus you are testing. You're testing for the medial meniscus. But if you're pointing it outwards, then you're testing the lateral meniscus. And the whole, oh, as you're extending, make sure to apply a varus or a valgus. If you just let the heel guide you. The heel will guide you to the most natural way the leg is going to come out. So if you move it in, it's going to naturally like I would sometimes just call it like you're externally rotating the tibia when you're pointing the heel in. The leg is going to want to naturally like do a bit of like a valgus movement. And then if you turn the heel out, or that's kind of more internally rotating your tibia, and you do this on yourself, like you see, like point your heel in and then point your heel out, and you'll see which direction the tibia is going. When you extend it with internal rotation of the tibia, it's the knee is going to want to have a valgus moment. And so let the heel guide you. But yeah, if any of those positive would just be pain. And also the reason why you're putting your thumb and your finger along the medial and lateral joints, if you feel clicking or locking or even pain along those joint lines, then it's positive. And you will feel those things with your fingers. So that's pretty much it. I know this was like pretty fast. Hopefully y'all were able to get something, but here are the resources and references. The UCSF Sports Medicine lecture series. I'll send this to y'all so that you can copy and paste this. Really, really great resource for not just shoulder and knee, but like elbow, hand, foot or ankle, back too. And then Physiopedia is always a great place to kind of like find like sensitivity and specificity for certain exam maneuvers. And there's just a shameless plug, since I'm from Jefferson. This 3-minute MSK peripheral nerve exam was created by our very own Dr. Hecker and Dr. Oncom, and a bunch of other physicians as well. But Dr. Hecker and Dr. Oncom are my bosses essentially, slash attendings. And this is just a really, really great comprehensive book that I think all of y'all should get, especially prior to starting your away rotations or starting your PM&R rotations, just to get a good understanding of MSK exams and peripheral nerve exam. All right.
Thanks, Adrian. That was awesome. Thank you so much.
Yeah.
All right. So who do we have left? Who's up next? Sorry, I lost track of my little list there. Dr. Robbie, you're on the call?
I'm here.
Oh, cool. Are you ready to go?
Yep. I was gonna add a couple more things, but I think
Oh, wait, because Dr. Ellie should be on the
yeah,
call as
I saw
well.
Dr. Ellis was next, but
Yeah, you're right. I'm sorry. I flipped the order on my notes. I apologize. Dr. Ellis, you on the call? Oh, sorry, we can't hear you. You're unmuted, but it looks like maybe the mic isn't connecting or something.
Or now?
Yes.
Okay, there we go.
Okay. All right, take it away.
Okay, perfect. Let me try the screen share. Let's see, how does that look?
Great.
Okay, super. So hi, I'm Rosalie. I'm a chief resident and PGY4 at MOS Rehab. And I'm here to kind of talk about traumatic brain injury. Hope it's fun. It shouldn't be too long. So what is a traumatic brain injury? So this is what the name explains. There is a trauma that happens to the brain that causes injury. And that trauma can either be a direct trauma, so like a strike to the head, a brick, a car windshield, something like that. But it can also be from just the brain itself sloshing around. So, like if a car stops too fast and the brain continues that momentum and hits the front of your skull and then the back, that also counts as a TBI, even though there's no external force. And it has to, cause an injury. It disrupts normal brain function. And so here's an example of that brain sloshing around. We call it a coup counter coup injury. Coup is the initial, if your car suddenly stops and your brain continues going forward, that where the brain hits the front, that's the coup. And then it'll slosh back, that's the counter coup. And that can cause a lot of damage, obviously. You are probably all familiar with epidural and subdural hematomas. Again, that's usually from an external direct injury. There's also something called a diffuse axonal injury, DAI. And the top picture, you can see all these tiny dark dots. Those are small microhemorrhages. So diffuse axonal injury is when there's like a shearing force in the brain, where there's a change of momentum, there's some movement, causes shearing in these long axons. And it can also disrupt the vessels in the brain too, which is causing those microhemorrhages that you can see in that top picture. The bottom picture is a different type of scan, diffusion tensor imaging, or DTI. And on the left, you can see that there are a lot of these lovely little rainbow lines, but on the right side, you can see some of them are missing, and that's because those are these axons that are sheared, that there's parts that are damaged, and you can see that more clearly in this type of DTI imaging. When you're on your rotation, they're not expecting you to know this level of knowledge. I just kind of want to paint the picture that TBI is very diverse, essentially, and there's lots of different ways that you can image it. So epidemiology. So there's 2.9 million TBI-related emergency visits each year in the United States. TBI does still include concussions, and so there's probably like so many more, that don't go to the emergency room. And so a lot of the causes of TBIs can be motor vehicle accidents, falls, and unfortunately violence. So what are TBI symptoms? Really, it could be anything and everything. Just kind of looking at some of these, I think, we'll just kind of go through them. Physical symptoms, headaches. This will be one of the most common ones that you will see both inpatient and outpatient. When you're looking at post-traumatic headaches, which is its own type of headache, You treat them based on what type of headache it seems to appear. So even though the official type is a post-traumatic headache, it might seem similar to like a migraine type. And so then you might use migraine type medications for it, for example. And so when you look at the sensory symptoms, there may be some sensitivity to light, sensitivity to sound. Those may be on its own, or it might be part of a headache picture. So you need to make sure you're asking all the right questions. Similarly, with the physical symptoms, dizziness, is this dizziness like the room is spinning? Is this dizziness from maybe orthostatic hypotension? Have they been in bed for a long time, especially when you're looking at the inpatient unit? So things can be really vague and kind of difficult to pick apart. So when you're on your rotations, becoming familiar with the types of questions that your attendings are asking to kind of tease these things out and try and think about why are they asking these types of questions? What are they trying to pull apart? And asking them about it later will be helpful. Of course, there can be a lot of cognitive problems, and so most people see speech therapy for that. Emotional symptoms, very common. There's agitation is very common in the moderate to severe traumatic brain injury, especially on the inpatient unit. But otherwise, emotional symptoms, I feel like is more common to be seen in the more concussive area and outpatient. You might see that a little bit more, and also the behavioral symptoms. I think most rehab hospitals have neuropsychology involved to some extent, otherwise psychiatry. So very important to get them on board if there's anything you're concerned about. Really, like all of rehab, we're a big team. We all work together, and so knowing who to go to and when you should ask for help, and it's something that will come with time. And so don't be afraid to talk to your consultants early, and just say like, hey, what do you think about this, as you're getting more familiar. Okay, so I've mentioned this a few times. So there's 3 types of traumatic brain injury. Mild is also called a concussion. So I've been saying that back and forth. There's also moderate and severe. This is kind of how you break it down. So when you think of a concussion, they should be unconscious for under 30 minutes. They might have gone out, you're doing sideline coverage and somebody hits their head, they fall down, they don't respond for a few seconds, then they come back up, and that's like a typical concussion. You should all be familiar with your Glasgow coma scales. So 13 to 15 is where you would expect them to be that first day. And then post-traumatic amnesia, we're going to talk more about that in a second, but it's essentially how long does it take them until they can create new memories? So somebody who had a concussion, maybe they don't remember getting hit. Maybe they don't remember being, brought to the sidelines, but then they start to remember things after that. So that would be, under 24 hours, typical concussion. Moderate, longer duration of unconsciousness, worse Glasgow coma scale and longer PTA, and severe, that trend continues. So what is PTA? Let's talk a little bit more about that. So I kind of like this picture. It talks about all the different amnesias. So going from left to right, we have, their pre-injury memory, and that's what's intact almost all the time. Most people will remember their name unless they had a very severe brain injury. And then we have retrograde amnesia, so something that happened right before the injury. And then you can see there's this black bracket on top that shows where post-traumatic amnesia can happen. The coma doesn't have to be there, that's optional. But if there's, it's from the time of the injury and then afterwards, if their brain is not creating new memories, then they're still in post-traumatic amnesia. And that includes anterograde amnesia to an extent. And so there's different ways that you can measure if somebody's in post-traumatic amnesia. Also, it's the most reliable way for people doing research to try and figure out how severe someone's brain injury was. If they're interviewing them long after the fact. And so some of those methods could be like, let's say someone had their brain injury in late June. And so the researcher, if they're trying to gauge how long the post-traumatic amnesia lasted for, they could say, oh, what did you do for the 4th of July? Do you remember the 4th of July? And so that's saying, like, were they able to create new memories by that point? So that's how that kind of works. Okay, so disorders of consciousness. I like this because it's a picture. So if someone's in a coma, they are not at your rehab hospital. They're in the ICU. True comas don't actually last that long. I think at the longest they will typically last is like 2 weeks. But if somebody's in disorders of consciousness, their family or other people might use coma, like the terminology coma, a little more loosely. Yeah. So after coma, you have unresponsive wakefulness syndrome, which is exactly what it sounds like. So they're unresponsive, they are not looking at you. If you put something in front of their face, they're not going to react to it. They're not going to follow it with their eyes. They're just there. But they are awake, so they have sleep-wake cycles. So that's why in this picture you can see their eyes are open. This was previously called vegetative state, except some people didn't like that. So now we have unresponsive wakefulness syndrome. Minimally conscious state, there's a minus and a plus, minus meaning closer to that coma state. Minimally conscious, a key finding is that they will track things. And so if you're rotating on a unit with the disorders of consciousness program, that's something that you may notice as soon as you walk in the door. So let's say you walk into the patient's room and then see if they look towards you. If they use, sound or visual clues to identify that there's someone in the room, and if they track you moving around. You can also put something in front of their face. A fun trick is to use like the mirror part of your phone, like so flip it around and put it in front of their face, because people's own faces are the most interesting things to them. You can also use money, but a mirror or like their reflection in your phone camera works really well. And you can use that to see, are they looking? Are they tracking? You can also use that to make sure that their extraocular movements are intact, because you can get them to go through the whole shape. So that's minimally conscious minus, and then plus is when they're following commands. So that's why there's that move your arm thought speech bubble. So then they can follow commands. And then finally, emergence is when they can respond back to you when they're talking. They're not necessarily talking, but have a reliable form of communication, whether that's like thumbs up for yes, thumbs down for no, or something else like that. So this is the coma recovery scaled, or coma recovery scale, CRS. You can Google this. I took the PDF and I chopped it up so it could fit on the slide. And you can see how it goes through different functions. So auditory function, visual function, motor function, and the better they perform, the higher score that they get. And if you look at the bottom right, there are some kind of key findings. So the star denotes minimally conscious state minus. Oh, so in general, the higher the number, the more likely you are emerged. And there are certain cutoffs, but what's really interesting is that if you get these certain activities, then that automatically puts you in that new category. So for minimally conscious minus, we can go to visual function scale, and you can see that if they're reaching, if they're following visually, if they're looking at things, they are minimally conscious minus, kind of like what we talked about earlier. Minimally conscious plus, so looking for something with that black box, object recognition, or let's see. Yeah. Non-functional but intentional communication. So that maybe, so they're trying to communicate. So you might have them do like a thumbs up for yes, thumbs down for no, and they might not be answering questions correctly, but that they are intentionally trying to answer questions. And so that would get someone that minimally conscious state plus. Also, of course, that reproducible movement to command. And then lastly, emergence, which is where we hope to get everyone. That's with that functionally accurate communication, and that's key. I was asked to talk a little bit about the Rancho Los Amigos scale. This is so I'm applying to brain injury fellowships right now. And so when I was on my first day of my brain injury rotation, I printed out this Rancho Los Amigos scale. And I was with my attending and I was like, okay, I'm really excited to learn this scale. And as we go on our rounds, I want to figure out where all of our individual patients are on the scale. And my attending was like, we don't do that. She was like, we don't do that in real life. That's for board testing. It's not appropriate to use in this way. So maybe don't do that. But it did make sense afterwards. When you look at your patients, you look at them as individuals. These scales are really helpful for some things, they're helpful for research, they're helpful for other things. But when you're working with your patients, you want to know, like, okay, if they are agitated, why are they agitated? What seems to be triggering their agitation, instead of just putting it on a scale. Yeah. But then, of course, there are other scales that we use more. But yeah, the Rancho Los Amigos scale is something that, at least for us in Philadelphia, I haven't seen that we've used it too much. The only exception is that so Rancho, ooh, I can see my mouse. Okay, a Rancho 4 is, that's almost like a saying, like, oh, we have a new patient coming in and he's a Rancho 4, so get ready, essentially. Confused and agitated. And yeah, that's really the only context in which we use the Rancho Los Amigos scale. So I don't think it's too important for you guys to learn that prior to your rotations. Know that there is a scale, know that it does exist, so that in the off chance where your attending does actually use it, that you can be familiar enough to look it up. But it's not something you're expected to know of ahead of time. Okay, so we briefly talked about agitation management a second ago. But yeah, agitation is common. One of our kind of review books, I kind of pulled some stats from it, and it said agitation has incidence of roughly 1/3 after TBI, which I feel like is about how often I've seen it on our inpatient units. And so the first thing you do when there's agitation is you want to ask questions. You want to see it in real life if you can. What is there a trigger? Is it that they get really agitated when they're, if they've gone to the bathroom and they haven't cleaned up yet? Like, honestly, I would probably be agitated too if I was in a wet diaper. Trying to answer some of those questions. Maybe, it's with family members, or if there's just too many people in general. If, there's a lot of environmental things that can be causing these agitation. And so you first want to start with that. You also want, still want to be that medical doctor, and you have to rule out everything else. So, is it truly agitation, or are they becoming more confused, more altered? Do you want to get a head CT to make sure there isn't any hydrocephalus? Do you want to get some lab work to make sure there's nothing metabolic going on? UTIs are common, and I don't think there's any infectious disease doctors here, but they do cause a lot of agitation, and treating them is important. Any endocrine, somebody's confused and sweaty, and is it that their blood sugar is too low? There's so many different things that it could be. And so make sure that you really be aware and try and put a lot on your differential diagnosis before you say, oh, they're just agitated. Let's, sedate them, or, hopefully you're not going into that mentality, especially not on your rotations. Oh yeah, so seizures. So yeah, specifically temporal lobe seizures, they can look very different from other seizures. And they might present as agitation, like, oh, this patient, he's so sweet, and then sometimes he's throwing things and gets so mad and this, this, that, and the other, and it might be a temporal lobe seizure. That's kind of an interesting, slightly rare, but not too rare one. Constipation, I mean, we talked about UTI. So to the right side of the slide, I have the agitated behavior scale. And this is something that we can ask therapists or nursing to document. It's not the best method, it's so much better if you have the whole picture and if you were there to see it yourself, but you're obviously not at the hospital 24/7 and you're not always available even when you are there. And so you can ask the other people working with that patient to kind of fill this out and say, like, to add things up and see how their total score is. Not only to get a sense of how agitated they are and how often, but also if you do want to start any treatment or intervention, then you have something to measure against to see, is this person getting better? But key point to take away from this as you go into rotation is, as soon as someone says this patient is agitated, just start asking questions. Say, what do you mean by agitated? What does it look like? And I think that'll be the most impressive way to show that you care about these people with brain injuries. Okay, and so you've done all those first steps. The next part is, what medications are they already on? Is things like Keppra are known to cause behavioral problems and to cause agitation. Anticholinergics as well, they can be, even so. With anticholinergics, benzodiazepines, and Ambien, there is a paradoxical effect that can happen where you would normally think that these medications are sedating, and then for some reason, sometimes they are very activating. And that can work to your advantage if you're trying to get somebody who is in a disorders of consciousness and trying to get them more awake and closer to emergence. But if that's not your goal, or maybe it was, but then you notice that they seem a lot angrier and they're throwing things and they're not progressing well in therapy anymore, then you maybe want to reconsider. We already talked about improving their environment. And of course, there's also hospital-acquired delirium, and you want to have, good day-night cycles, but maybe limiting the amount of bright light if that seems to be a trigger still. So you're really working with people individually. And then lastly, we have medication management. So you can use antipsychotics and benzodiazepines very rarely. Yeah, super, super rarely. Haloperidol and risperidone, although very common on like acute, in the acute hospital stay, we never want to use that with our people with brain injury. There is so much research showing that it's just so bad for their brain recovery, and it can actually make their agitation worse. Benzodiazepines also impair cognitive function. They, again, will limit how much they can really benefit from therapy. And if you do have to do something, propranolol has always been mentioned as like the best first line agent for treating agitation. There's just the most research for propranolol. That is like I wouldn't call it like a pimping question, but it is a question that we've been asked as residents of, like, what's a good medication for agitation? And everyone always wants to say like Seroquel or an antipsychotic first, but the answer is propranolol. So if you can remember that for your rotation, I think that would earn you a lot of points. let's see. So the last thing that I was asked to talk about are the model systems, specifically the TBI model systems. So I just wanted to mention there's 3 types of model systems. There's burn, spinal cord injury, and traumatic brain injury. Model systems are part of a healthcare center, and so they really model systems you can expect to provide the best evidence-based care. And something that's unique and really kind of the reason the model systems were developed was because they collect research. And so there's a traumatic brain injury model systems, TBIMS, or if you're in the know, you call it TBIMS. And so there's been research going on for the past 35 years. And so the way it works is, so for example, MOSS, where I'm a resident, is a traumatic brain injury model system. And so we will have patients come onto the inpatient unit after having maybe a moderate to severe traumatic brain injury. And then we have researchers who might swing by their room, talk to their family, say, hey, is it okay if we include your information into our national database? And so that national database includes information, including, how their injury occurred, a lot of their medical records, including like the results of their like imaging, also some of their therapy records. So we learned a little bit about FIM scores earlier, so it includes their FIM scores, things like that. And then afterwards, there is a follow-up at years 1, 3, 5, and then every 5 years after that. And so we have 35 years of data on some of these patients, which is really neat. And so here's some of the TBIMs or the TBIM centers. These are from 2022 to 2027. It's a very competitive thing to become a TBIM center, and these, I guess I could call it a scholarship. These grants rather only last for 5 years, and so every 5 years they have to apply again. Yeah, really cool. So I'm at Albert Einstein Healthcare Moss Rehab. Amanda Rabinowitz is my research mentor, and she's just like the best person ever. And doing research at a residency with a model system is just so beneficial and so wonderful, and it really has helped me so much. Okay, so here's something we kind of already talked about. So each TBIM center, and I imagine it's the same thing for spinal cord injury and burn. I just don't work with them as much, so I can't say for sure exactly what they're collecting. But yeah, so again, the emergency records, records from the inpatient. Also, oh yeah, so like social questions, like, so I'm doing research that involves like psychiatric history. And so we want to know, prior to their brain injury, did they see a psychiatrist? Were they ever hospitalized? And then, we can compare that to their after the brain injury, like to see maybe what impact the brain injury had. And then, yeah, collect information at 1, 2, 5, and then every 5 years after. So here's a paper that Dr. Rabinowitz, again, my mentor, worked on recently. And I just wanted to show you what cool things the model systems can do. So they wanted to look at some trajectories after moderate and severe traumatic brain injury. And so if you look at, let's see, like participants, 5,000, that's a lot. If you were to try and get that many people to enroll in a study on your own, that would be a lot of work. And so it's so neat that they can just request this data from the database and be able to, crunch numbers, see if there's any significant correlations or anything going on. And yeah, we don't have to talk too much about this, but just something neat if you know that you want to go into traumatic brain injury, something to think about when you're applying to residency. And these are, another thing to think about when you're applying to residency, not only is it a traumatic brain injury model system. But is there a traumatic brain injury fellowship? That is something else that would be important. So going to a residency that hosts a fellowship will give you such a leg up when you are actually applying to fellowships. And so here's just a list of all the places that currently have TBI fellowships. The one at Moss is definitely within the top 10, easily within the top 5 TBI fellowship programs in the US. And so I'm extremely lucky that me just existing there as a resident makes me a competitive applicant for fellowship. I'm applying for fellowship right now, so clearly that's on the brain. But Moss Rehab is great. We have a lot of fun. And I'm happy to answer any questions if I didn't talk about something. But in general, when you're on your rotation, whether it's inpatient or outpatient, and you're seeing people with brain injury, speak slowly, be compassionate. And I think that will really just show. You don't have to know a lot. We just want to see that you're a good person, and that'll be the most impressive. And that's it.
Thanks, Dr. Ellis. That was wonderful. I think last person up is Dr. Robbie, and then hopefully a few minutes for questions.
What's up, everyone? Hi, I'm Robbie. I'm a PGY3 over at Penn State. Did my med school down in Tampa, Florida, Nova Southeastern. Originally from Newark, Delaware. Excited to talk about stroke. Wanted to give a quick shout out to my awesome attendings, Dr. Pamela and Dr. Pieta, for helping me out with this one. Let me share my screen. Can you guys see?
Yep, you're good.
Cool. Let me start this off. So start with the basics here. So stroke, the fifth leading cause of death in the US and leading cause of disability worldwide. So mortality from strokes has declined since the 1950s with the advancement of medications that we have, early detection, making sure from door to CT scan to treatment, that whole system has been optimized. And of course, the rehabilitation has definitely helped here as well. Some non-modifiable risk factors, of course, for stroke, increasing age, sex, male, if male greater than female with the risk factors, race and family history. Some modified risk factors I've listed here, like high blood pressure, prior stroke, heart disease, AFib, smoking. Kind of wanted to make this interactive. If you guys want to just type in real fast, out of the modified risk factors, which one is the most important?
We got hypertension rolling in the chat.
You guys are definitely smarter than I was when I started, so I went to smoking right away because that was the first thing that went to my head. But yeah, it's a high blood pressure. People, I think of it as like, oh, you can definitely convince someone to smoke, but if you're not controlling their blood pressure, then it's all for naught at that point. Give me 1 second. I don't know what happened to my screen. Oh, there you go. So now going through the types. So you're gonna have 87% of them be ischemic strokes. You can see on the top right here, the whole dense pocket of ischemic area right here. Usually that's in the frontal side on the left. And 48% of the ischemics are going to be thrombotic, 26% embolic, and then 13% lacunar, and then the other 13% outside the 87 is going to be hemorrhagic. On the bottom right, I like to show an MRI. That's what an embolic stroke would look like. You see a lot of just throwing of different parts of ischemia here and there with typically AFib throwing little balls of clots throughout the brain, causing this type of stroke here. It's important when uh, you're going into your rotation to try to master your anatomy as best you can. Of course, your attendings won't expect you to know it like by heart, but it's important to know the idea and always try to get better at the anatomy. So ACA coming out of here, MCA rising up over here, and then the PC posterior communicating rising down here, and then ending with the posterior cerebral artery here. Coming up from the posterior side, the vertebral artery going up here matches meets the other vertebral artery into the basilar artery right here. So learning the circle of Willis is super important for your rotation, knowing where the clot is, knowing where when you look at the imaging, it's like, okay, what am I expected to see clinically after I look at this person's scan? So when you have an admission, when you're working with the resident, the attending, typically you chart check them, you see their hospital course, and then you check their imaging and see like, oh, if there's a stroke here, what is this patient going to possibly look like when I do their examination when they eventually come to inpatient rehab? So what supplies what? So the medial cerebral artery, the lateral hemisphere as it goes outwards, the ACA, the medial hemisphere, and then the PCA, the posterior inferior surface of the temporal lobe and the visual cortex. So MCA, the superior aspect of it, you'll get sensory and motor deficits, contralateral face and the arm, and you may get a little bit of leg, but it's mostly going to be the face and the arm. So you have if you have a left-sided MCA stroke, you can possibly get a global aphasia, but you can also get a Broca's aphasia. I'll get into aphasias a little bit later. And then also you have the right-sided. If you have right-sided MCA stroke, and they'll get deficits spatial perception, hemi-neglect, constructional apraxia, and dressing. So what do I mean by neglect? So if they're left side dominant with right sided effects, typically they'll ignore everything that's on their left. So, for example, if you see the patient, they're sitting down, you you put like an apple or a pencil on the left side of the desk, and you try to ask them to pick them up. They may not be able to and try to reach over for it, but they won't be able to get it. If you have them draw a clock, they may draw the right side of the clock correctly, but ignore the left side. Typically, our therapists, when they treat these patients, they'll use prism glasses to help try and correct their neglect and do spatial teaching for them. And then the inferior side of the MCA, you'll typically get the Wernicke's aphasia, and then left side in visual neglect. On the ACA, you can get sensory and motor deficits on the contralateral leg, along with a lot of executive function issues like personality disorders. PCA, so I think talking about the PCA is super interesting. I actually had a patient with Anton syndrome when I was on my stroke rotation. So you'll get visual field cuts. So in the PCA, right, you're not gonna see a lot of motor issues with typically with patients with PCA strokes. You'll go examine them and they'll be like 5 out of 5 strength almost everywhere, but then there'll be issues with their vision, which is because hitting the PCA will hit the occipital lobe, which helps control vision. So in Anton syndrome, typically you'll see patients where if occupational therapy tries to test their vision, they'll fail completely. But what will happen is they'll be like, oh, they'll confabulate and think they're seeing something like, oh, I think I saw like glimmer of light on the right side, or I think something moved there, but they're completely blind. They're kind of unaware of their deficits. Some things that also happen are prosopagnosia, unable to read someone's faces, and alexia, on being unable to read. Uh, in the vertebro-basilar artery group, it'll supply the midbrain, the pons, the medulla cerebellum. That any strokes there can cause vertigo, nystagmus, uh, bilateral motor function deficit, so both sides are affected. You can have ipsilateral cranial nerve dysfunction on that side. Um, yeah, and then I think we wanted to go over some stroke syndromes as well. So a couple of the high yield ones I have here, the Wallenberg syndrome, or the lateral medullary side. So in the brainstem, you have the midbrain, the pons, and the medulla. So it'll be the lower aspect of the brainstem on the lateral side. So easy thing to remember is you'll have uh, anything that's affected medially of the brainstem will have motor disorders, and everything on the lateral side. Typically, motor is not going to be seen as an issue. So you in Wallenberg, you can have occlusion of the vertebral arteries, pica, superior lateral medullary artery. What will happen? You'll get an ipsilateral Horner syndrome. So along where the medulla lies laterally will be some sympathetic branches, and with the stroke affecting the sympathetics there, so you're going to get meiosis, you're going to get ptosis as well, and it's just going to look a little. That side's going to droop. It's going to be droopy. It's going to be pinpoint pupils, and there's going to be a lack of sweating there. You'll also get ipsilateral face and face pain, temperature loss, ipsilateral ataxia, and then contralateral arm-like pain and temperature loss. Because on the lateral side, cranial nerves 9 and 10 will be affected, you'll get dysphagia and also vertigo. Weber syndrome, which is the median midbrain, so the upper portion of the brainstem, you'll get motor dysfunction, since on the medial side, that's where the corticospinal tracts lie. You'll also get ipsilateral cranial nerve 3 paralysis. So if you remember the mnemonics from med school, uh, the oculomotor nerve will be able to look up and down, except go laterally, which is the abducens cranial nerve 6, and then down, which is superior oblique by the trochlear. So what's going to happen with a ocular motor nerve paralysis? The eye is going to look down and out. You can also get contralateral Parkinsonism as well. And medial medullary syndrome. So that'll be the occlusion of the penetrating branches of the vertebral arteries and the anterior spinal. What lies there will be cranial nerve 12. So you're going to have ipsilateral hypoglossal palsy. So if you think about it, the tongue won't be able to switch to the other side. It'll stay flaccid on that same side. So the tongue's going to face towards the lesion. And because it's midline, you'll get contralateral hemiparesis, since the corticospinal tracts will be affected, and then also contralateral sensory loss. I don't want to dig too deep in the acute care, because that's typically for your neuro rotation, but a couple things just to be aware. Of course, if you're thinking about the stroke on the ED side, you're going to get a non-contrast CT head. An acute infarct on CT head will look hypodense. However, that lesion may not be seen until 24 hours after. If it's a hemorrhage, it's going to be bright white. So, of course, one of the reasons you get the non-contrast CT head is if you can see if you do not have a bleed, this patient can be considered to get TNK if it's necessary, if it's indicated. I have here, for if you get an MRI of the head, typically edema will come out as a hyperintense signal on T2, which means there's the presence of water there, and then any hemorrhage will look hypointense. Of course, don't forget your ABCs, checking your blood sugar, doing an EKG, getting troponins, getting those basic labs is also important. Checking, make sure they're breathing properly. A couple of things you'll see on the notes when you get your discharge summary from Neuro. They typically will manage blood pressures IV through IV, lobetalol. They will be on cardine drip. They'll use clofidipine as well. Let's see. And then I put in here, you don't need to go through all this now, but I'll just look up inclusion criteria and exclusion criteria for patients who would be able to receive TNK acutely. Now for the good stuff, now once the patient is in rehab, just want to dwell on a couple things. So there's going to be poor prognosis of recovery of useful hand function if the patient comes into the rehab with already complete arm paralysis. Uh, Typically, if motor recovery of the hand can be done around 4 weeks, there's a 70% chance of full good recovery overall. Some things that can be a poor prognosis is uh, having no grip strength by 4 weeks of inpatient rehab, having severe proximal spasticity on onset, prolonged plasticity as well. Treatments that we use here, positioning, range of motion, mobilizing the joints, helping with purposeful movements through OT and PT, E-stim, non-invasive brain stim, and of course medications. Um, I know you'll see patients who typically may develop spasticity in their rehab course. There's a lot of, I guess, theories and different beliefs in how you should treat these patients. One of my attendings, Dr. Pieta, she is a firm believer that she doesn't want to treat specifically the spasticity until outpatient and let the spasticity run its course. And sometimes people can use that spasticity to help with their movement. So you'll hear this a lot when you're in a stroke rotation, the Brunstrom process of recovery. So typically a muscle becomes flaccid at first after a stroke, then becomes spastic. Patients able to gain controls of the synergistic movement. So typically in upper extremity, you'll be flexed, and then in the lower extremity, you'll be extended. But patients are able, with training by therapists, can help gain control of that. They master their movements. Hopefully, at that point, the spasticity can disappear, and then they have normal function. Of course, that's the ideal world, but this is more just a theory that people turn to in terms of recovery. You'll hear, I don't want to draw in too much of this either. You'll see different theories about the of how you treat these patients with we hear about the Bobath theory and the Brunstrom theory. Bobath, they're pretty much trying to inhibit any non-normal movement. So if it's spastic, they try to treat the tone, and they try to inhibit any primitive patterns of movement, meaning after a stroke, typically the CNS will regress to um, movements like how Babinski, typically you see that in children and young babies, and it goes away. With the inhibitory aspect of the CNS, they're trying to treat those primitive patterns. And in Brunstrom, it's kind of like the opposite. You're actually trying to use those primitive movements to help improve motor control and help train the body to use those energies to their advantage and help with recovery on that aspect. Um, Not super high, but I think it's important to see where the theories lie for stroke rehab in itself. Things that we treat while we're here. So you'll see a lot with especially the MCA stroke shoulder subluxation. It'd be I think it's gonna be good brownie points for rotators. You say like, oh, if patient with a gap in between the shoulder head and the glenoid, what can we do? Typically, it's taping them e-stim to the shoulder, putting them in a sling to help support it. Um, I talked about spasticity earlier. You'll see the upper extremity flexor and lower extremity extensor patterns. Typical treatments we do outpatient will have antispasmodics like baclofen, the GABA B agonist, benzos, which I don't see typically used a lot, especially for spasms, but you'll see Valium or diazepam used. you'll see tizanidine, an alpha 2 agonist. Um, and your outpatient rotations, you'll see the providers do Botox injections, phenol injections. Of course, all of those are great, but if you don't have a PTOT helping out with stretching, the patients being able to go regularly to help manage their spasticity is it's all for naught if they don't go to therapy and help with stretching and help with purposeful movements. And of course, there's splints, orthoses, intrathecal baclofen pumps, and different surgery they can use for tendon lengthening. Other things in the rehab hospital, there's of course DVTs to be treated. There's wound care to make sure that because these patients are have less movement, aren't able to offload weight or transfer, there's risks of having sacral wounds, heel wounds. Um, Also, bladder and bowel dysfunction, super important. You can get incontinence from neurogenic bladder with the effects of the stroke. You can also get a UTI. Um, Patients can present in numerous ways. They can retain, they can have a spastic bladder where they're just outputting urine and they're unable to control themselves. Things that we treat, we can do time toileting, meaning if we get them on like a regular schedule, they're able to avoid completely without having any act trying to avoid accidents if they're incontinent. Bladder scanning, typically the orders that we do, we try to scan them every 4 and try to get them to urinate in a specific schedule, like I said before. And if they have too high residual after we try to get them to pee on their own, we'll have the cath. And some other drugs that we try to use to avoid that are the antimuscarinics to help them fill, to allow them to urinate more a lot better without being more spastic, and then alpha 1 agonists like Flomax. And of course, bowel dysfunction. It's kind of the same thing for the bladder. You'll do a lot of time toileting for this. Um, Dysphagia, super important. Not every stroke patient's going to have dysphagia, but it's good to know. Tips, you'll have speech language pathology follow these patients. You'll start with a bedside swallow in the inpatient side to see if they're able to swallow, and they usually go from there. If the patient needs meets criteria to go under a barium swallow or a video photographic swallowing study, you're able to see all 3 phases of swallowing: the oral, the pharyngeal, and the esophageal. With that, so you're able to use compensatory techniques, different postures, bolus modifiers to see which which maneuvers it would help benefit the patient to get them to a more improved diet, a more normal diet. And then there's the fees, which my rehab hospital uses, the fiber optic endoscopic eval swallowing. It's comprehensive for just the pharyngeal swallowing in particular, but it can evaluate swallowing physiology, coordination of the swallowing muscles, and any presence of residue there. And I think this is also one of the more important parts of my presentation is the aphasia tree. Um, when I was learning in medical school, that I only really learned 2, which is Broca's and Wernicke's. Uh, but it's actually kind of a fun mental activity for myself when I go into a patient's room and I try to figure out, okay, if this guy is aphasic or this man or woman is aphasic, which one will lie? So questions I'll ask about fluency, basically, can this patient speak properly in a good cadence and can you understand them? So that kind of starts when you're walking in the patient's room saying hi, trying to see how they talk. A lot of the global aphasic patients, they'll say a lot of gibberish. They might even be mute. They'll be like, "Oh yeah, this can I and they'll just repeat stuff and you cannot really understand them, can't really understand the contents of what they're saying. Now, what's next is can they comprehend? So typically I ask, can you point to this? Can you point to your face? Can you shake my hand? Can you point to the floor? Just asking them just to follow different commands. And it's you can determine if the aphasia they have is a safe aphasia, meaning can they follow tasks properly and can they be safe at home where even though they can't produce what they're saying, they're able to understand things, understand what people are telling them so they can be safe at home. And then the last test is if they can repeat things. So my attending usually just says, can you repeat, I want to go to bed, I want to go to bed, I want to go to bed. I want to see if we can repeat different phrases like that. You can see which after all those questions to see which aphasia you get. I'll give credit to Darsh Shaw down in Tampa. He was the senior from last year. The a mnemonic that he came up with was get my butt to Miami where the sun comes around when the sun comes around. So that always worked for me. It worked during my SAE. So whatever works for you though. And last thing I wanted to mention is post-stroke depression. You'll hear a lot about the flame trial if you're on a stroke rotation, talking about SSRIs helping with motor recovery. It would be nice to like look up a little bit before you start, but a lot of these patients post-stroke, they'll develop depression because of loss of function. It's important to get inpatient neuropsych on board and maybe even consider starting an SSRI, not only because of the motor function, but it would help their mood and it would help their rehab stay. And things like seizures as well, high risk, especially for people of older age, if they're confused, especially if they have large hemorrhages in the parietal and temporal area. And typically they'll be generalized and tonic-clonic. I think that's it for me. Sorry, I ran a little bit late, but
Oh no, you're absolutely good. Thank you so much for taking the time.